This is Jennifer Bumpus. She's your liaison with Wise Health up here on the corner. So if you have questions, problems, appointments, she's your point person. Your cards are in the back.
Yes, my cards are back here.
And call her before you call the doctor's office. Call her, she'll give you the directions, all the particulars that you need. Dots the I's, cross the T's, and she'll take care of you. And I'll leave it over, turn it over to you.
Yes, if you have any problems at all, please call me. That's my job, is to fix the problems. So if for some reason you go and see the doctor and the doctor's office was not what you were expecting, or it didn't meet your standards or anything at all, please call me and let me know, because that's what I handle. I handle all the doctor relationships. So please let me know. You can also, if you don't have my number, tell Mr. Behringer and he will send me an email with your name and contact number, and I will reach out to you. Okay? This is Dr. Benae. And he specializes in back, spine, and brain. So he's going to talk to you a little bit about all of those issues, pain management, how to prevent this type of pain, and then what you can do about it. Okay?
All right. Good afternoon, everyone. Is it working?
Hello? Yeah. All right. First of all, apologies for being a little late. Came from Frisco and I had to drive a little bit around here. But just before we get into the topic of back pain, just want to let you guys know a little bit about me. Again, my name is Jean-Louis Benae. I'm originally from Cameroon. It's a country in Central Africa. From Cameroon, I moved to Paris, France, where I did some high school work. Then I moved to California when I was 19, and there I went to college, med school. And I went on to doing a residency in neurosurgery in Wisconsin. Then after Wisconsin, I took a job in Mississippi, where I did brain and spine surgery over there as a consultant in one of the multi-specialty clinic for about 3 or 4 years. Then I moved then to Frisco, to McKinney actually, around 2013 to open my own practice. So it's called North Texas Brain and Spine Specialist. I've been over there since 2013. And more recently, I've been coming here in Argyle at Wise Hospital to help some of the patients in this area with back pain mostly. Okay. So the topic of back pain is a very big topic. It's a very complex topic. We'll try as best as we can in the next 15, 20 minutes to touch on the most important part of it. Now, some numbers, it remains a problem that's very prevalent, as you can see in the slide, the leading cause of activity limitation and work absence worldwide. Again, the pattern of back pain is extremely variable, and the way it affects people, it's so different. And it's not unusual that we see patients that have the same imaging abnormality, yet they display a total different set of symptoms. And also in the same pattern, they will all respond differently to the treatment algorithm that's given to them. And that's really why when it comes to back pain, one needs to have an approach that's really individualized to the patient itself. And as you can see in the slide, it remains a problem that's very costful to the community and to the society in general. So some keywords. It's fundamental to try to understand a little bit of anatomy. I'm not going to bore you guys with the details, but understanding that the back, what's the role of the spine? The role of the spine is to support our weight. So it's going to play a certain level of biomechanics that's important to understand. And when you think about the spine, again, I'm going to focus on the lower back and mostly on the degenerative problems that come with low back pain. You can see that it's a set of bones that are lined one on top of each other. And then in between the bone, there's some intervening cartilage. Do we have a pointer by any chance? No? That's right, no problem. So the cartilage is there intervening, and that's where the joints of the spine is. And the most fundamental part of that unit is going to be right at the interface between the bone and the cartilage, and also from the back here, you see those other joints that we call the facet joints. So you've got the disc and then the facet. Those are the parts of your spine that will usually undergo degenerative changes, and by that I mean they will go through the process of wear and tear and build up a bone spur and lose the integrity. And in the process, they will have they will create a condition whereby the nerve that are close by will become compromised. They will start getting irritated because they will be pinched, or the spine will lose its integrity and become unable to do its job, which is to support your weight. So, it's really fundamental to kind of have a visual understanding of what really is at stake here. And as you can see in this page, in this slide here, the role of that disc is really important, is because that's where you gain your mobility, that's where the spine gains its mobility. And it's also important to understand it because when it comes to various treatment that involve the spine, particularly if we ever talk about treatment that are surgical, one will have to think about how do we treat while preserving that motion, or do we have a problem that we can only treat by losing that motion, which is when you hear a lot about fusions and things like that. And I will touch on that later. So, what are some of the major causes of back pain? Usually we can divide it into three major points. We have the mechanical causes, which is by far the majority, the non-mechanical, and then the visceral causes. So when it comes to mechanical back pain, which we'll kind of emphasize on a little bit more, that emphasizes most of what we call the degenerative back pain, or the arthritis in the back. Because keep in mind, we hear a lot, oh, my back is I just have arthritis in the back. But mind you, even that arthritis can cause change in your back that becomes so debilitating that they may need some treatment. And it's not just because it's arthritis that there's not an answer or a treatment for that. There are possible ways for us to alleviate the pain and then the conditions that are causing these debilitating issues. Now, instability. That's when the spine loses the ability to do its job or to support your back. Trauma, obviously, you sustain a fall, and there's some other people that are maybe born with genes that are making them more prone to develop deformities in their spine. All these will be patterns that will lead to a set of symptoms that can be debilitating. So, at the end of the day, the two major things that we look for in the spine is one, when there is compression of the nerve, and two, when there is instability or weakness of the spine. At any time when your back is going to bother you, the two fundamental questions to ask will be, are the nerve compressed? If so, which side? And the symptoms that you have, let's say your right leg is bothering you, and you take a picture, we take an MRI. We should be able to see that on the MRI, on the right side, the nerve is compressed there. So it can explain your symptoms. And the second fundamental thing is going to be, has the spine lost its integrity so that it's loose or unstable? And those are the two major things that from a structural standpoint, a surgeon or a physician in general should be looking for and addressing. So, the degenerative disc disease, again, like we alluded earlier, the disc, which is the cartilage between the vertebrae, is what starts undergoing some degenerative changes. And in the process, there are usually three major factors. The number one is really the genetics. We all get born and come to this world with a set of genes that are going to determine how the spine will change over the years. So some of us have a little bit more predisposition to our spine issue than others. And the second thing that happens is that as we go through the years in life, the wear and tear that the spine undergoes will also affect it. So what do I mean by that? A person, for instance, over the years that has carried a bigger weight, has put more strain on the back of the spine, or has done a lot of activities, deadlifting, a lot of weightlifting, things that will probably put a lot more strain on the back, will definitely get to see these changes happen more so than the person who did not. And thirdly, the trauma. You know, if you have a pattern of activities that puts you at risk of falling, getting into car accident, all these trauma can also impact on the spine. And those three factors are usually what I've seen over the years. That tends to be the major determinant of how people's spine look like at a certain point in their life. Now, what makes it even more complex is that we all have nerves that have a different ability or a different capability to deal with this pain or with these abnormalities. In other words, person A may have a set of nerves that can tolerate these changes more so than person B. That's why it goes back to what I said earlier, which is you may see 5 patients with the very exact same abnormality on their pictures, yet they all have 5 different set of symptoms, yet they all respond to the same exact surgery totally differently. And that's why for a patient, for instance, and I can see that it might be a bit difficult, it can be, it's important that when you try to understand your problem, your back pain, that you don't always necessarily compare it to maybe your cousin, your uncle, your neighbor who has had the same issue, because the bodies are totally different, even though they look the same, even though the imaging look the same. It's something that we experience on a regular basis. But again, here you can see that the changes really occur at the level of the disc, the cartilage. And as you can see in the lower part of the picture, essentially when that cartilage, when that interface between the bone and the cartilage starts going through the degenerative changes, this is where the nerve will come out, and you can see that there's adequate room for the nerve to come out. Yet here, where there's been a lot of changes, that area is totally pinched off because bone spurs are now built up, and then they can start causing some symptoms. Again, that's just a picture that kind of again the importance of understanding how the anatomy is critical to learning about how to fix this problem. And this is just another picture that kind of gives another example of the steps of the changes that occur. And in terms of the degenerative changes, when I say that the disc or the cartilage goes through changes, what happens is that very early, when it's more healthy, there's a little bit more of water molecule into that cartilage. You think of the cartilage like a sponge. If you have a sponge that is a little bit moist, it has the ability to compress and regain its size without problem. But when it loses that moist or that water content, it becomes difficult. So it's like a structure that is designed to tolerate or to take strain and pressure. But when it loses that flexibility, that's when all the symptoms can start coming, and the spine becomes a structure that becomes more flared up. There's a lot of flare up, there's a lot of inflammation, and all that leads to the symptoms that come afterwards. So, all right, just not good. Again, this is just another example of how the changes that are occurring, because the nerves are very close to these structures. These changes get into affecting the function of the nerve. And when you think about the nerve, you think about 3 major functions. The nerve is going to be that structure that's going to interact with either the muscle or part of your body and provide sensation, provide all the electrical needs for the muscle to work, or allow you to feel certain form of sensory function. So when the nerves start dysfunctioning, you may start feeling pain. You may start having electrical type feelings. Sometimes it feels like your extremity is cold. Sometimes it feels like it's burning. And then over time, when it's not treated, the nerve is going to start affecting the function of the muscle itself. You start having some weakness. And if that's not properly treated as well, then the muscles start losing the bulk of its shape, start losing its strength, and then the bulk, and you start having a muscle that is atrophied. And again, when it comes to nerves in general, you really don't want to wait until you get to that stage where the end organ, such as the muscle, has lost its bulk before you treat, because by then, the neurological deficits and the damage may be advanced enough that even if something is done, we may never recover that function, which is one of the reasons why I've always really recommended to all the physicians and patients in general that when it comes to a problem that may involve nerve, it's best to get all the specialists involved from an early stage, because we all have different experience, we all have different knowledge of what's going on. For instance, seeing a surgeon very early in the process does not necessarily mean that you're going to have surgery, but rather someone who has the ability to do something as early as possible is involved and is also part of that team, so that when decisions are made, it's not just made by someone who does treatment that does not involve surgery. It's best that you have the physical therapist involved, the pain management involved, the surgeon involved, not in an intent to necessarily do the intervention, but rather to balance and shape the decisions of others. Because, the more and more that I'm in this field, the more and more I'm finding out patients do best when we expose them to a variety of specialists within that field from the get-go. For instance, in back pain, most of my patients, I will make sure that while they're seeing, they get to see the physiotherapist at the same time, they get to see the pain management doctor at the same time, so that we can all see and come up with the proper treatment algorithm. Because sometimes patients feel that, okay, well, I've done A, B, C, D type of non-surgical treatment, I'm still not getting better, so automatically it's time for surgery. But really the answer to that is no, because sometimes you may have done all these non-surgical treatment modality, you're still hurting, but surgery is not going to be an answer. So it's very important that that surgeon gets involved from the get-go and assesses that, okay, from a structural standpoint, we don't see a problem here that will ever need a surgical intervention. That way, even from a mental standpoint, the patient is informed and aware of the options that are there from the get-go. So again, risk factor, I kind of touched on this earlier when I talked about the genetics and then the environmental, the pattern of work that you do will affect how your spine will look later, because again, the spine is that structure that really supports your weight, and it's very important in our daily activities. So again, so what are some of the typical symptoms, just to kind of bundle them under one umbrella? Pain, numbness, tingling, difficulty or limitation with range of motion, when you feel that if you lie or you adopt a position of rest, you feel better. Those kind of symptoms tell us that your spine, which is again that support structure, is starting to lose its ability to do its job, which is to support your weight. And I think when that is the case, it's very important to, even if the symptoms are very mild, to get someone, already make someone would make your physician aware of them, because at this early stage there's some simple treatment modalities such as some exercises that could aim at strengthening part of your spine that you can do very early. So we always have a much be ready to discuss the symptom rather than waiting and trying to deal with them by yourself. And I think it helps if the early you make them aware to your physician. All right, how do we evaluate generally these problems? One will have to get a complete history and physical examination, identify the mechanical pain generator. And this is where I think we all differ as physicians as well. When it comes to spine, one truly needs to answer this most fundamental question: what is causing pain? What is at the root cause of the problem? Because, again, I have seen so many patients with image of their spine that look horrible, but they're so active. They're running, playing golf, playing soccer, and have no problem. Yet I see another patient with images that are, relatively normal, but they're crawling to come to the office, they're in a wheelchair. So there's a lot of things that don't make much sense, and until the patient and the physician sit down to answer the most fundamental question, which is, where is the pain coming from? Are the imaging that we have able to explain the pattern of pain that we have, the symptoms that we have? Because you're going to find out very quick, there's some physicians that are very quick at looking at a pathology or an abnormality of the image and making an aggressive treatment solution right there, yet not making sure that the pattern of the abnormality can explain the pattern of the symptoms. And it goes down to that fundamental question. It's kind of like an investigative work. It's not because it looks abnormal that it necessarily explains the problem. And if it does, how does it? And these are things that you need to inquire about to your physician. And to me, it's a work that involves the patient significantly. And at times, some patients just want to have a more laid-back approach and let the physician do everything. But in this business, when it comes to back pain, I would encourage you all to take the time to demand the proper education about it, because it can make a significant difference. And if the decisions are not taken right, particularly when it comes to the spine, they can have a really tremendous and significant negative effects. Because the spine is fundamental, it carries you, it's got all the nerves there. And again, the nervous system, unfortunately, is such that, God forbid, one gets part of the nervous system damage. Like I said earlier, you may not be able to recover that function. So it's not like a muscle or part of the body where they can go through an injury and recover from it. But when an injury to the nervous system, to the nerve, is deemed permanent, more than likely that recovery is not capable of taking place. So again, in the process of evaluation, you want to look at the psychosocial status, because that's important. That can play also into affecting the patient's perception of pain. There's other factors in our lifestyle that may get and change how we perceive pain. And it's important for the physician, at least, the patient may not always know that, to really be able to dive into that area and be able to see if there are not any factors around the person's personal life that may be giving them a heightened or a more elevated, a more pronounced comprehension of their own pain and experience of that pain. And if that's the case, it's important to sit down and lay it out to the patient so that they understand, because you may go and operate or take a surgical or a treatment decision based on a situation whereby 80% of these symptoms are probably aggravated by a patient's particular psychological status. So workup, typical workup, beside the examination, we want to do some imaging, we want to do some nerve tests because we work around the nerves. So these are things that it's important to gather as much data as possible. Again, like I said, it's kind of an investigative work. And this is just a simple example of X-rays. And you want to start with the most simple studies, which is the X-ray. And the X-ray really gives us a good idea of what the spine looks like. And when you're going to take this X-ray, you're going to want to make sure that the X-rays are done in a manner that you have your body being supported by the spine or on the supine position. And again, the next important thing is the MRI. And with the MRI, it gives us a little bit more details about what the nerves look like. And that's really what's fundamental. If you find an MRI like this one here, which shows where the nerves are compressed right around the right there, as you can see here, there's brightness all over. But right where you've got the little circle there, everything is compressed. It means that there's a potential for nerve malfunction. However, in person A, there may be deficit there because they may have problems from that. In person B, they may not. So in my book, the person that is affected by the problem is the one that's going to get a treatment, not necessarily because it looks like normal. Yeah. So I'm not going to spend more time on this. This is more of the different type of treatment that, diagnosis that people use. Now, in terms of treatment option, when it comes to back pain, you want to maximize conservative measures because many people do well with conservative measures. There's some pain management, some interventional pain management where these kind of treatment can be helpful for some kind of patient. And then surgical options are also there. And when it comes to surgical option, you want to make sure if it's at all recommended, you look for the one that can provide you the treatment or the surgical option with the least invasive possibilities. Okay. So here I also have a chiropractor and pharmacotherapy medication that just falls under the conservative measures. So and I really encourage patients to consider physical therapy a lot because we've had a lot of data that have shown that even with advanced pathology or advanced abnormality, therapy can really work for some. But at the same time, one needs to recognize that when the therapy becomes limited, meaning that you start having numbness, you start having weakness, you start having those signs that the nerve is not tolerating the condition, then you will want to make sure you look into some of these options that are more surgical. And these, again, have the habit to talk to more than one surgeon because we all have different options, different experience. We all have different training. We all have different set of experience. And I think the physician or the surgeon that will be on ease with you seeking a second or third opinion, you should ask yourself why. Because if one is sound about the treatment that they're offering, this should be okay to have you talk to someone else and in fact hear that the other second opinion is giving them a recommendation that is similar to what you've given. So, and that's something that in our practice we do very often. We make sure, again, we have that multi-specialty approach whereby the pain management, the physical therapies, and then the surgeons get to talk to the patient from a very early point. And if at any point I sense that the patient is not just really is uneasy about things, I really encourage them to see someone else because this is tricky, it's complicated, and you need to arm yourself with all the data and then all the knowledge that is possible. In fact, in our clinic, we make sure there's a good part of this process that involves patient education, which kind of falls into why I'm here today. And I think it's really, I really want to commend WISE for putting together such a program because we need more of that. And I'm saying it because I've been doing this thing for many years, and there's still times that there are questions that I have. There's still times that I don't understand how things end up, how a treatment does not work for one versus the other one. So for someone like me that's been around it for a long time, I can just imagine how a patient that has no knowledge of this, all that I'm talking about, will feel. So we really try hard to spend time with the patient about these problems. In fact, whenever a surgery is recommended, we really make sure the patient has a good understanding and can tell us what it is that they're going to go through, because I'll tell you, you hear this 1-2 times, but it's not that easy. So really, the one advice that I will make is, first of all, when you have back issues, be very proactive about seeking help. Be very proactive about seeking more than one person to help you about it and educate yourself about it. Ask questions. Take the opinion of surgeon or Dr. A and bring it to Dr. B, and because doctors will never talk. Dr. rarely talk. So take that and go to them and then essentially question their decision, and you have to do that. And that's how you get to understand really as much as you can, because even after all these years, there's still certain things about this this field that we've been learning every day. So I can just imagine how much more challenging it will be for the patients.
I have a question, Dr. Benae.
Please.
What could they do at home to help treat their pain that they're having? Just to kind of help get them by or maybe alleviate some of that pain?
Yes, so I think at home, again, it depends on the severity of the pain. One thing that is already good, which is exercises has been well known to help with low back pain. So stretching exercises, just low activity or low strength strenuous exercises, being already very aware of the fact that the spine supports your weight, so you want to optimize your weight so that it doesn't put a lot of strain on your spine. But activities, being active is definitely something that is good. Swimming, aquatherapy, and just exercises, walking, all that is good. On the same token, it's important to know that if you're getting to do an activity that is generating more pain, then you definitely don't want to continue with that route. And please, I'm open to any questions, because if I keep talking, I'm just going to keep talking till tomorrow.
Comment on spinal stenosis.
Please, yeah, okay, spinal stenosis. Spinal stenosis, I'm going to go back to a picture that I had here, this one or even this one. Spinal stenosis is the process whereby there's degenerative changes that occur around the spine, and then it narrows the space where the nerves are. Like here, all these spaces where the nerves are, the brightness here tells us that there's adequate spinal fluid, which is what we all need to have around the nerve. The nerve hates anything that rubs on there. Down here, you can see that there's a process whereby there's abnormal tissue that's pushing into the space called the spinal canal, front and back, and narrowing that space. And that's what's called spinal stenosis. Stenosis just refers to the narrowing of the space for the nerve. And when that's the case, then the nerves are pinched. Depending on the level that the problem is occurring, that's going to determine the type of symptoms that you have. If it occurs much lower in the part of your spine, your lower back, you're going to have more problem with the lower part of your extremity, your feet, your legs. You start having difficulty holding yourself up. You're going to see that. Pay attention, people that have spinal stenosis, when they're walking for a little bit, like you go to the mall, they're going to be doing what we call the shopping cart syndrome. They walk like this on the shopping cart. Because when you lean on that, when the spine adopts a certain flexed position, it naturally opens up that space. So the brain just pushes you to adopt that position because you want a little bit more room. Now, with spinal stenosis, it's very important to understand that yes, you can do some exercises, but frankly, it's a structural and mechanical issue. So you just need room for the nerve. And there's a lot of advanced, minimally invasive way to create that room. And what that will mean that you come here in the back of the spine and clear all that tissue so that it's open just like that. Now, to that, you're going to have to make sure the spinal stenosis, you're going to hear a lot out there. People want sometimes to treat spinal stenosis by doing a little bit more than just relieving the space and providing the space around the nerve, and also putting some hardware or creating a situation whereby they put screws and fuse that segment. And that's where you really want to know about the fact that stenosis can be treated without having to do all of that, because stenosis is merely the effacement of the space around the nerve, and is treated by providing that space around the nerve without necessarily putting any hardware, because anytime we violate the spine to that extent where we put hardware, if it's not truly indicated, it's only going to be detrimental. Please.
Can you just kill the nerve around the area that's affecting, get causing the pain, just get rid of the nerve or kill it, whatever, I don't know, killing the right one.
Good question. So it depends, okay, because kill the nerve is terminology. Let me just kind of explain what we do when we hear. It's called radio frequency ablation or rhizotomy. You probably heard a lot about it. It's actually the nerve area that you burn. But but you don't really destroy the nerve because you can't really destroy that nerve because you still need that nerve. What you do is that the nerve ending that detect and get stimulated when they stand, you can deaden them. Unfortunately, it's a process that has a timeline. So it tends to be the one treatment algorithm that provides patients with the longest relief, and by that I mean months. Sometimes I've seen some patients 8 months, 1 year, rarely more than 1 year. Yeah, but really, it's nothing that is long term. And again, it will not really apply in the stenosis because in the stenosis, you've got a mechanical problem where the nerve is being choked. You just need to provide room for that.
So is that a surgery for the spinal stenosis? Does that require surgery then, or is there an exercise you can do to stimulate that?
Good. Definitely, I will first offer exercises, but I'll tell you I'll have a very low threshold to proceed with a surgical intervention if we don't have a result because I know it's a mechanical issue. So if the exercise don't help, I will not waste time sending the patient back to the exercises or to the injection because this is a problem that could be fixed by providing the space. That was another question.
And what is a laminectomy?
Yeah, a laminectomy is a process whereby we remove part of the lamina, which is the back part of the bone. So, on this picture, we come here. So, this is part of the vertebral body, or it could also be the disc. So, this is a section of this, a cross section. So, this is the space where the nerves are. In this particular picture, you have a piece of disc or abnormal tissue that's putting pressure into the space of the nerve and compressing some of the nerve here on the left side. When you look at this, usually this is the right side, this is the left side, because we're looking into the plane of the patient. This is the belly is here, and then the back is here. The lamina is this bone here, back here. If you are able to feel the middle of your back, that is a spinous process, and from that spinous process comes the lamina, and the lamina is going to have a left side, a heavy lamina on the left or the right side. So if you want to get to the middle of the spine where there is compression, you're going to come and have the lamina removed. So the laminectomy is the process whereby you remove the lamina in the back, and data and studies have shown that you can do that without weakening the spine, but at the same time, that lamina has a role. So if you keep doing laminectomies, eventually that could weaken your spine and place you in a situation whereby you now may need hardware to strengthen that spine. Now, rather than probably doing a full laminectomy, what more of the surgeons that are more into minimally invasive approaches will do, they will do rather a hemi-laminectomy or half a laminectomy or a laminotomy, which is making a hole in the lamina. Laminectomy means you take the whole lamina out. Laminotomy means that you make a hole in the lamina that still allows you to get there and do the job that you have. So I think, for instance, you have someone who says, oh, well, you need a laminectomy to fix this problem. Then the question that you have for the physician will be, what about a more reduced removal of the whole lamina? Is there a way this problem can be done by doing just a laminotomy, a small removal? Because ultimately, we cannot underestimate what we do to the spine. It's got a repercussion. The more you do this, the more you see that.
I
Yes.
do have another question. It's a follow-on to that. This is a what if. What if you had stenosis surgery on your upper spine, a laminectomy on your middle spine, and a fusion on your lower spine, and you still have back pain?
I guess it's a very common problem, and I think that goes back to what I said earlier. What is causing the pain? Let's sit down and figure out, because is the pain caused because there was a treatment that was inappropriate? Because sometimes, again, like I said, we go after what looks abnormal. It's not necessarily what's causing the pain. Now, the other thing to know is that there is also such a thing as what we call failed back surgery syndrome. That's when, like I said earlier, everybody's nerve is different. There's some folks that have nerve that despite what we do, they're always going to be in pain. Fortunately, technology that provided us what we call neuromodulation. Neuromodulation is the treatment modality whereby when we have a patient that is still in pain despite everything, what we do, we try this spinal cord stimulator, which you've heard maybe. In some patient it works, in some other patient doesn't work. Because ultimately, what makes you feel that you're in pain is a set of a firing of nerves that go into your brain, and the brain gives it an experience that you're in pain. So now there's been a technology that has evolved over the years that allows us to place some electrode in your spine to dampen all that shooting stimulation that goes to the brain. And the good thing about it is that it's a treatment that is first tried, and we see how it works if for a week, and if it works, then you are deemed to be a candidate that could benefit from that. Then we implant it. It's just essentially a paddle of electrode that is placed in your mid-back and connected to a battery and set to different settings, different electrical settings till we find what works for you. The goal of that paddle is to dampen all those nerves that are firing to your brain to make you feel that you're in pain. So in that case, like you said, multiple surgery, I'm thinking this is probably a failed back surgery syndrome. Meaning that despite addressing structural abnormality, we still have a good set of symptoms that's present. And obviously the first exercise would be, let's see if we have a real and a clear definition of what is the root cause of the symptoms. If we cannot find a structural root cause of the symptoms, then I'll have to say the nerves are just on fire. Probably that category where nerves just get on fire. There are questions there.
Yeah, the nerves repair themselves once they get damaged. Is there repair for nerves?
Good. So typically, again, it depends on the severity of the damage. It depends on the location of the nerve. When you think about the nerve system, you think about the brain, you think about the spine, and from the spine, you've got nerves that end up in your extremity. We've learned over the years that the peripheral nerve, which are the nerve that go from the spine to the rest of the body, those can have the ability to slowly repair, but very, very slow. And for instance, if you section one of those nerves, it's going to take years for it to grow, to sprout out. A lot of time, the neighboring nerve around can, for instance, if it's superficial, the neighboring nerve will have to go and cover that area. But when you talk about central nerve injury, meaning that at the level of the spinal cord, we have not had technology that is really convincing that they can repair. And that's why when someone has a spinal cord injury, they're on the wheelchair forever.
My wife doesn't have a spinal cord injury. She has shingles. It's never left. It's been due to damage that come out of the back, of course, the nerves that come out of the back. And, is there a hope for them repairing themselves, or is there any, or cut them off or something to stop the nerve, the pain out of it?
Yeah, so if it's peripheral like that, sometimes you can really, again, go back to RFA whereby you can numb the nerve ending and address the level of the pain. So there's some option with interventional pain management where they can deaden the nerve ending and help with the severity of the firing. But as far as repairing the whole nerve for it to be back to what it was before, I'm not aware of technology that exists for that yet. Yes.
Yes, could you address what the surgery might look like to create the space for the spinal stenosis and maybe what the recovery looks like?
Yes, so essentially the surgery is providing room in that spinal area, which is most time coming from the least destructive approach, or the best approach that will be to come posteriorly and then remove some of the lamina, because if this is the lamina, a lot of time this area has gotten a lot of arthritic tissue that has grown and is pushing. So when you remove some of the lamina,
You can then gain access to that arthritis tissue, including bone spur. If it's a disc in the front, you can shave that piece of disc. If it's thickened ligament in the back, you can clean all that off. So typically, depending on the level, the number of levels that are involved, it's a relatively straightforward surgery. I think I usually like to tell patients, give a grading from a scale of 1 to 10 in terms of complexity. For these lumbar stenosis surgery or laminectomies, I will usually grade them 2 or 3. So in terms of complexity, not as complex. But again, you know, even if it's not as complex, nonetheless, it's still a surgery, you know, and everyone responds different. You have to take into account the patient's comorbidities. But really, by far, it's a relatively tolerable surgery that, you know, in the hands of an average surgeon, I think the outcome should be good, very good. In terms of recovery, I will usually say anywhere between 6 to 8 weeks, you know, but the good thing about that kind of surgery is that you can notice immediate benefit as soon as you get up, because the nerves are totally decompressed. Now, when it comes to the back incision, you gotta give it time to heal, and those tend to be a little bit challenging sometimes because we don't see them, so we don't have the ability to detect that, oh, geez, it's not healing right, and get involved right away. Or like maybe a front of the neck incision that you see every day, and then if there's any slight abnormality, you will notify your physician. But really 6 to 8 weeks recovery.
I have a question about pain medicine.
Yes.
So what you would say the best or strongest over-the-counter pain medicine that they could take for pain, and how long could they take it for before they really need to be seen by a physician?
Yeah, again, it goes back to the fundamental question, what's causing pain? If the pain is the kind of pain that is due to nerve irritation, you know, again, over-the-counter may not have an option. But in general, when when we talk about the degenerative issues to the spine causing pain, we think that there is an inflammatory process. So anti-inflammatory in general. I would strongly advise for any of the anti-inflammatories, but you have to make sure you are not a person that you know, does not have any contraindication from taking some of these anti-inflammatory medication. You know, if you have kidney problems and things like that. But for by far, anti-inflammatory will be the type of medication that I would recommend. Now, when you go see a physician and then you have the opportunity to get a prescription, then if the pattern of pain is more so just superficial muscular, you really just want to keep it to a muscle relaxer. If it's the pattern of pain that travels down the extremity, it's like burning, it's like a nerve, then you want to have what we call a neuropathic medication, such as, you know, Lyrica or gabapentin, because those are more specific to those kind of problems. But really, over the counter, I would say anti-inflammatories.
If you have a
Laminectomy?
No. It doesn't last, or is that just good for a couple of years?
Good question. So typically, when you have a laminectomy, it should, if it's done properly, meaning that because again, it's always the most fundamental thing, doing the procedure properly to address the goal of surgery. Because you could do a laminectomy, but it's this tiny little laminectomy you end up not benefiting from it because it was not wide enough or adequate enough to relieve the pressure. Sometimes surgery can be stressful. I've seen, and that's where experience come into play. Sometimes you deal with a patient that is obese, that is difficult, is challenging, and as you expose there, the visibility may not be the best. Depending on your ability to deal with this kind of issues, you may take the time to just, take a deep breath, take the time to go through the challenge, and you do everything, or just do the quick and what makes it easy and simple, and then you have a suboptimal result. But technically, when you have a properly done laminectomy, that should be a surgical treatment option that, if done properly, you don't need to worry about it. It's not like it's going to last for a certain amount. Now, the one issue that may arise is if the person, for instance, after the laminectomy is a person that has a lot of scar tissue, or a person that scars a lot. And even then, several years will go by before the scar tissue starts irritating the nerve. Because scar tissue, you can't really always control it. At times, you have to go back and clean up a little bit of scar tissue. But really, to answer your question, a properly done laminectomy should be a definitive treatment option, surgical treatment for a patient's stenosis.
Scoliosis that develops as an adult.
Yes, good. Degenerative scoliosis, that's what it is. In fact, I have a picture here. This is it here. This is degenerative scoliosis, meaning that as these discs and these cartilage and joints start losing the integrity, maybe the disc is like that. Initially, it's nice, parallel structure. The right side starts losing its integrity, it becomes smaller. The left side hasn't changed, and then that's how it tilts the spine. And in the process, it's going to pinch the nerve here and then create a mechanical situation that prevents your spine from properly supporting your weight. Degenerative scoliosis, I think, if it's a treatable, condition. Obviously, like any other spine issues, I would want to optimize non-surgical treatment in a series of therapy, injection, until we get to the point that either the symptoms are becoming tractable, or now we have a new onset of neurological deficits that are not acceptable to keep. In that case, we will have to essentially provide a realignment of the spine and relieve the pressure of the spine. Unfortunately, in case of scoliosis, if you need to realign the spine and relieve pressure of the spine, you're going to have to do a lot of laminectomies so that you can loosen up the spine and clean up where you have the stenosis. But also, you're going to have to put hardware screws, titanium screws, to line that up and hold it in a certain, because with hardware, you can dictate the spine to be in a certain shape. Now, when you have it, there's something that comes with it too. You lose some range of motion, but the pain might be better. And then now that you have hardware, the hardware is going to make that part of your spine immobile, and therefore the level above that are mobile are going to be undergoing a lot more strain. And your physician should let you know that there is a possibility that those levels may definitely also at some point experience the same problem that the other ones have, because now it's being overworked. So yeah, there's some option, but definitely you want to maximize non-surgical option, and when surgical options are recommended, if the pattern of the problem is such that you can address it in a minimally invasive fashion, you want to request that, you want to ask about it. For instance, with something like this, if we need to correct this, we need to go above and below the apex of the curvature. So surgeon number one may say, okay, I'm going to go from this level to this level and make this straight, which is probably where the majority of the symptoms are going. Surgeon number two will be, no, I'm going to go from here all the way to down here. So both of them probably are right, but what is going to make the difference is asking them, what am I gaining by going all the way up and down? Have you seen something up here that necessitates that we extend the work up there? Because there's always going to be abnormality. And my philosophy for this is going for what causes the majority of the problem. I would probably focus on just a short segment treatment. It's going to make, the spine is not going to look all perfectly right, but yet we're going to save some other level to maintain some mobility.
I'm not going to do that. Not my age. If I were a younger man, perhaps, but what could I do without doing what you just said?
Good. So again, it goes back to non-surgical treatment, where you will do, exercises, strengthening exercises, combination of exercises with injection. And again, I think ultimately, what matters really is how is the problem affecting you and really.
What kind of an injection?
Spinal injection. And spinal is just an area, it's a lot of spinal injection. It could be epidural, it could be the rhizotomy, like the RFA that you mentioned. It could be the injecting into the joint, the facet joint. A lot of it depends on what we think is the cause of the pain. If in this process there's significant compression of the nerves, I mean, we can try all of that, but more than likely the result will be suboptimal. Okay? And that's the thing, being able to be truthful about what the treatment is giving you, and being able to be truthful about what kind of expectation you should have, the patient should have right after the treatment. So, and it is true that this is a topic that comes a lot. Oh, well, I feel that I'm too old to have this kind of surgery. Do you think? And I'll tell you this, not to promote doing surgery, because ultimately you want to do what's right for the person. And at times what's right for the person is not doing anything, because the outcome of doing something might be just detrimental. But in some other folks, I have a good set of patients that are at a pretty advanced age, but very active, but very functional. So then you have to have a valid reason to. You can't really prevent them from having the treatment that they need just because of the age. I've had patients that are 50 years old that look like they're 90. I have patients that are 90 years old that look like they're 50. So I think it's a question that demands a big view and overall view of the patient, their functional status, what they're doing. And then obviously I get a lot of the physician involved, because if a surgical decision is going to be made, we all need to be on the same level, same point, that, okay, what can we do? What does your cardiologist thinks about it? Everybody should be there. And really have a truthful discussion about what to expect. And the reality is that at times, a person can be really, really limited, and that could change their way of life, and then they become depressed because they can't do anything, and ultimately you ask yourself, why did you offer the procedure? So I think it's kind of case by case, and you just have to be someone who can understand what's the functionality of the patient, what is right for them. Yes.
Can you address pain management as far as for muscle relaxants and narcotics in 65 and up? Because as you were saying, all of us are different. I had an experience where, because I was over 65, I was told that I could not be put on a muscle relaxant because I might fall. And so I was at pain between 8 and 10 and was told to go home and do Tylenol and ice.
No, obviously that wasn't right, that's not right. So again, when it comes to pain management, again, it goes back to every patient is different. A normal pain management physician usually, in the battery of testing that they do, involves doing some blood work that also understand the kind of enzymes that people have, because we have different enzymes. We can give you a medication that your body metabolizes so quick and it doesn't work good for you. And which is why I'm not a pain management specialist, but a lot of my colleagues that I know, even when I was doing a little bit of pain management with my patient, we do a lot of testing to see the kind of enzyme that you have, to see the medication that may work for you. There's some genetic testing for things like that, because there's some patients, like I said, that will not do well with some medication, because you give it to them, they want to take more, and it doesn't work on them. So you have to have the flexibility to try different ones. And also, the typical issue with muscle relaxer is usually with regards to heart condition. If a person has a heart condition, because when the heart is a muscle, you don't want to give them, or if you're going to give them muscle relaxer, you want to make sure you give them a small dose, or you try something that is not going to be detrimental to their heart. And other thing is, like, you look at other comorbidities that they may have, where the muscle relaxer may be a problem. But in general, I think it's wrong to just say, oh no, you're over 65, you can't get paid, it's your thing. Yes.
Question, you're talking a lot about chronic pain. Just a question on more of an acute pain, which you might get from lifting something too heavy or whatever. What would you say are the symptoms that you should seek, or what would you say are your indicators that you should see a doctor?
So let's say, you've done some work and then all of a sudden you feel some really bad back pain. I think first, give it a few days of rest. If the symptoms do not improve, I will then at some point seek medical help. If at any point you see that the symptoms involve any type of electrical type feeling, pain, burning, coldness down the leg, so anything that will make you feel that maybe a nerve might be involved, you want to have a lower threshold to seek some help rather than waiting. Obviously, if at any time the pain is intractable, that by itself, the severity of the pain, it's an indication to do something. And in that kind of situation, very early, it's very good to get just anti-inflammatory, anything that will cut down the inflammation, and see how you respond to that. I'll just give it, usually there's a big number in medicine, 3 days, 72 hours. If things don't get better, then I'll start looking for answers.
Thank you.
When you talk about your colleagues and your team, are you involved with the group right now? And where is your office? Where do you do these things?
Good. So I'm by myself, but my practice has always made an effort to closely interact with other doctors that do other things that I do, and even those that do what I do. It's very typical that when a patient comes and sees us, either here in Argyle or in McKinney, we'll initiate automatically evaluation with the other specialists, such as the physical therapist and the pain manager, because they come to me because they're in pain. Now, depending on the severity of the pain, I always ask them if they feel that the pain needs to be addressed while we try to answer this question, where is the problem coming from? I get the pain management involved. If I feel that they're going to need more than what I can provide, we get the physical therapist too. Now, if we're dealing with a problem that maybe does not have, is a tumor, for instance, in the spine, we don't really need therapy for that. We just need to get to the tumor and going. Then in that case, I will handle it.
So you say you refer the
Yes.
patient to these different people?
Yes.
And then you come together and make a decision?
Exactly. So what it is specifically, I will refer them to the other physician, and then make sure, again, when we refer them, we make sure we see them so that we can discuss the result of the referral, the result from what the referring doctor say. And at times, I will even refer them to other neurosurgeons. If I don't feel that my answers are convincing them, or if I feel that I will want to see what another physician will think about it as well. Because again, like I said, some of these are not straightforward. And over the years, you learn that the more you humble about it, the better it is for everybody.
Where do you do your surgeries, or where is your office?
Yeah, so I have an office here in the Wise campus. I'm here every other week, but the main office is in McKinney. I do surgery here in the Wise Surgical Hospital here, and I do surgery also in Frisco, in McKinney, in Addison. It's a little bit everywhere.
How about pain management? Do they have it in
Yeah, pain management, I'll usually try to refer them within the vicinity of where they live, and to a colleague that, like here, there's some other pain management doctors that we kind of work with who will refer the patient to them. And also as far as physical therapy, same thing.
Thank you.
Yes. Oh, yeah.
One more question. A lot of people, the biggest complaint that I see about pain in the ER setting is sciatica pain. And they want to know, what can I do right now to help it or alleviate that pain? Is it something that they have to come in for, or is it something that they can do something at home to kind of calm that down?
Yes, good. Again, it goes back what's causing sciatic pain. If sciatic pain is due to a disc that's herniating or maybe a bone spur, more than likely what's going to happen is that it's going to irritate that nerve. Depending on how serious that is, I will definitely initiate therapy, exercises, stretching, and if the symptoms are intractable, one will probably benefit from a short course of a neuroleptic medication, such as a neuropathic medication, such as Lyrica or gabapentin, but that's a prescribed medication. But again, if you go through those exercises, it doesn't help. A lot of time, patient will do well with, an epidural steroid injection. Now, if we're dealing with the cause of the sciatic being a big disc herniation, then that disc needs to be trained. Because over the year, there's been a lot of terms that have been used inadvertently in the world of spine, so that don't really make it difficult for patients. I hear a lot of people say, oh, it's just sciatica, but sometimes the sciatica is due to a big disc herniation that's pinching the nerve, and it needs to be addressed. And sometimes non-surgical treatment are not help for that. Or it's just my arthritis flaring up. The arthritis could be exactly what I showed you there. All this starts with arthritis, and it can get more and more advanced. So have the threshold to not want to try to answer those questions yourself, but seek help. And if you feel that the symptoms are persisting after a few days, really seek help. All right. Thank you, guys.
Thank you.
Thank you, Dr. Oh, yes, I wanted to add one more thing.
Yes.
Just in general, our pain management specialist that came to see you last time, his name is Dr. Riley Pena.
Yes.
So Dr. Riley Pena has moved offices, so if anybody has tried to call him and has gotten zero response or zero answers, it's because he has changed offices. He is now in Dr. Ward's office in Denton. He's still credentialed with us and still working with us. He just, his contract was up at that office space and he didn't want to renew. He wanted to get in with a big group. That way he had the office staff and the resources to kind of support him, because it was just him and an office manager, and that wasn't enough for the influx of patients that he was getting. So he is still with WISE, but he's at Dr. Ward's office in Denton. But if you have any questions, if you have questions for Dr. Benae or you want to see him, please pick up my card, give me a call. I will direct things however we need to and take care of everything, okay? Thank you guys so much for letting us come.
Thank you.
Thank you.